Hello, everyone. It's a pleasure to be here and to speak to you today about the HEARTS technical package and its relationship to diabetes um, and chronic kidney disease. Thank you for the introduction, Vicki. Um, Here are a couple of learning objectives that I'd like to just go through very quickly, and I'll try to touch on throughout the talk. First, want to build on the prior presentations by Dr. Rosende and Dr. Bretler to discuss how diabetes care and chronic kidney disease care fits in within a HEARTS framework that has primarily focused on hypertension to date. Also talk about the ways that these diseases kind of come together to potentiate or cause end-stage problems. And then also talk about how hypertension in particular is a key component of diabetes care and how that's important to remember, as many of you already know. So I have a few kind of main teaching points that I'd like to just come back to. I kind of touched on them on the prior slide, but these are kind of in different language. The first kind of premise I'd like to tell you about, and again, I know that many of you will be living this on a day-to-day basis, but there's just a significant implementation gap in hypertension and diabetes care in resource-limited settings. I primarily work in Central and Latin America, but I also work as a clinician in the US and have worked at federally qualified health centers. And this is true in the US as well, of course. HEARTS, as the people who have come to the prior presentations, is a really novel, compelling state-of-the-art tool to help us address this gap. And then finally, the argument I really want to try to drive home is how high-quality hypertension care is really a key pillar of a fundamental cornerstone of high-quality diabetes care. So I wanted to just start off this talk with a case. This is a man who I met in 2013. His name is Julio, and I was meeting him. I met him in Guatemala, actually, in a rural area in Guatemala, where I was working at a clinic. He was about 42, 43 years old at the time. He had diabetes and hypertension for about 10 years. And he'd been hospitalized a couple of times for acute hyperglycemia. And unfortunately, he was discharged and just could never basically afford medications, which is unfortunately a common story, I think, around the world, in the US, in Guatemala, everywhere. In particular, insulin was extremely prohibitive for him. And so he would go to the hospital and then he'd get discharged, and then they'd tell him to buy insulin, and he couldn't, and then he'd get sick again. And the cycle that many of us know, unfortunately, happened to him. And after about 10 years, he presented to us with leg edema, with decreased urination, with some eye problems. And I'm going to tell you a little bit more about him in a second. But just to kind of tell you about his situation and how the challenges that he faced and how I think HEARTS might kind of make a difference, could have made a difference in his case. This is more or less the kind of rural area of Guatemala where he lives. Beautiful area, quite isolated. There are health clinics in this community, but there are no health clinics that offer diabetes or hypertension care, believe it or not. This is not his house, but it's a pretty similar house to where he lives. As you can see, like he lives in a very humble home. He had a couple of young children between the ages of, I think, like maybe 3 and 9. And unfortunately, due to his diabetes, he no longer could work. And I wanted to this is a slide from one of the private pharmacies in the area where he works, where just to illustrate how medications are so expensive relative to the amount of money people make, that they're among the most valuable resources in a given community, and they're actually guarded by armed guards. You can see this man with a shotgun here with these bars, because the cost of insulin might be as much as a half month's salary. And I think there's a lot of similarities, unfortunately, with how expensive insulin is here in the US. And so I'm going to come back to his case in a little bit, but just to kind of set up about how untreated hypertension and diabetes and the impact it can have, and how context in high quality care can make such a big difference. When I met this patient in kind of 2013, 2015, that period of time, I was actually in the middle of my internal medicine and pediatrics residency. And this was the federally qualified health center where I was doing my continuity clinic. And this was in Minneapolis. And this clinic was really interesting to me because it served a large immigrant population. And so I saw a lot of patients who were very similar to the type of patient I just presented to you, this man Julio. And what was most remarkable to me was how similar so many of the challenges are, both in the US and outside the US, frankly, in terms of people accessing and receiving kind of high quality, sustained, non-fragmented chronic disease care. And how the burden of the complications from diseases like diabetes and hypertension are unfortunately experienced primarily by people who are more marginalized or have less ability to pay for their medicines or to have health insurance. So let me just take a step back. This is a slide I always try to present, especially when I'm trying to make the case that diabetes is something we need to focus on in addition to high blood pressure. This is a slide from the Lancet in 2016. It shows on the y-axis here the number of adults with diabetes around the world. And on the x-axis here, you can see year from 1980 to 2014. And the more recent data is actually coming out soon. I'm a co-author on that paper as well. And basically what you can see is this incredibly impressive exponential growth in diabetes around the world. And so diabetes is a problem that's affecting everyone, all communities. And the burden is really, really increasing, both due to population aging as well as the penetration of lifestyle, low physical activity, and diets that tend to be conducive to causing obesity and diabetes. And the HEARTS technical package is, I think, a really ideal pathway forward to really think about how we can deliver better population diabetes care. And I know that Dr. Rosende and Dr. Brettler talked to you a little bit about HEARTS before, but maybe if I could just, for those of you who maybe weren't at those presentations or don't recall, if I can just give a 1-minute summary, which may also kind of help to set up the rest of the talk. So HEARTS is a package or kind of a bundle of really, they're basically quality improvement interventions. I think it's the easiest way to think about them. And the idea of HEARTS really actually came from the US, especially the work of Kaiser Permanente in California, thinking about ways to really improve population level care of hypertension. And of course, in the US, we've had clinic level and population level quality improvement indicators. We as physicians are often subject to them. But what I think was really novel about the Kaiser program back in kind of 10, 15 years ago was how the system level incentives were coordinated in a way that really facilitated the delivery of high quality hypertension care. And I'll go through the different components in a second. HEARTS is an acronym. But after this Kaiser work was published, the World Health Organization took up this idea of a package of implementation kind of quality improvement interventions to really scale up population level hypertension care. And so in 2016, they released this HEARTS technical package. And then since then, in the Americas region, the Pan American Health Organization, as Dr. Rosende might have told you, has really taken up the mantle, focusing on kind of the improvement of hypertension care, mostly in countries outside the US, but there's no reason that this can't be implemented at scale in the US, just like Kaiser did. And that's what I think we're so excited about in presenting to you today. And then HEARTS hasn't traditionally been as focused on diabetes, and that's where my kind of work and my research really comes in. I'm really interested in thinking more creatively about how we can develop population level strategies that are very synergistic or integrated with the HEARTS hypertension components. And just like in hypertension, the quality of diabetes care around the world is unfortunately very, very low. This is a graph from a paper that came out last year. On the y-axis, it shows the proportion of people receiving a given diabetes treatment. And then on the x-axis are different treatments. And so, for example, among people who are eligible to receive glucose-lowering medication, this is in a sample of 55 low and middle-income countries, only about half actually received glucose-lowering medications. Only about 40% received blood pressure medicines, and actually less than 10% have received statins or other cholesterol-lowering medications. And the delivery of lifestyle counseling on diet, exercise and weight loss is also quite low, only about a third of patients. That's outside of the US, but in the US, we're not doing that much better. This was a paper that Elizabeth Selvin's group at Hopkins published last year in the New England Journal using NHANES or National Health Survey data here from the US. And if I can just walk you through these panels just to set up why this is so important. So this panel up here in the upper left shows the proportion of people in the US from 1999 to 2018 who have adequate glycemic control. So depending on the threshold that we're using, between 50 and 75% are achieving glycemic control. Similarly for blood pressure, maybe 48% to 70%. Lipid control, about half as well. And when you combine these different risk factors among people with diabetes, only 20 to 25% are achieving adequate control of all these risk factors. And so, we really need to develop, implement kind of better strategies that are going to let our patients get the care they need. And one of my key kind of things in my own research and clinical career that I've really been focusing on and building on some of the work of my mentors at the University of Michigan, but also really trying to take up the mantle within the HEARTS framework, is the role of hypertension care among people who have diabetes. This was a modeling study that I participated in last year, where we tried to model different scenarios in terms of scaling up treatment for diabetes. So not only medicines to lower blood glucose, oral and insulin, but also medicines to improve blood pressure control and cholesterol control. And what we found here, which has really kind of been my thesis statement, is that reducing complications from diabetes is likely to require a focus on scaling up blood pressure and statin medication treatment and blood pressure medication titration, rather than only focusing on increasing screening or improving glycemic treatment. And that's kind of been a key piece of the research that I've been doing in Guatemala when I've been working with the Ministry of Health, is really reminding them about the critical role of blood pressure and statin medication therapy among people with diabetes. This table, I think, is one of the last kind of research bits I wanted to present to you. But this is a table that came from John Yudkin, who published it about 10 years ago. He's been a mentor of mine as well, as a very, very renowned diabetologist. And what this shows is for kind of the three main modalities of diabetes treatment, if we want to think of cholesterol control, blood pressure control, and blood glucose control, for a given medication on average, how many people will we need to treat over the course of 5 years to prevent one cardiovascular event? And what he and his team kind of drew out from the literature based on their kind of review of the meta-analysis and clinical trials was that, roughly for one statin medication, you need to treat about 44 people over the course of 5 years to prevent one heart attack or stroke. For blood pressure control, one medicine, you'd have to treat about 30 people over the course of 5 years to prevent one heart attack or stroke. But for glycemic control, you'd have to treat about 120 people over the course of the 5 years. Now, of course, blood glucose control is really a critically important piece. But my kind of message when I speak with policymakers, especially in the research setting where I work in Guatemala, is that we can't forget how important other pieces are as well. Earlier this year, I had the great honor of being asked to write a paper in the Pan American Journal of Public Health by the Pan American Health Organization to try to actually think more formally about ways that diabetes care can be integrated into the HEARTS hypertension framework. And I'll go into that in more detail. And we're happy to share the link or the PDF to this paper later. Frankly, nothing that we wrote here is cutting edge or groundbreaking in terms of never being seen before, but we really wanted to think about how we can systematize the clinical treatment of diabetes in primary healthcare, just like HEARTS has already succeeded in the case of hypertension. I gave you a little bit of epidemiologic data, but just to kind of really bring this home, this is a table showing the number of deaths that are attributable to different modifiable risk factors in the entire Americas region. So not only the US, but across the entire Americas, Canada, Brazil, Mexico, the whole kind of continent of North and South America. And the left panel here shows the leading risks in 1990, and then the kind of the right panel here in 2019. And as you can really see, the high blood pressure and high plasma glucose have really become the dominant modifiable risk factors, and now they comprise over 30% of all deaths in the Americas region. So we're talking over 2 million deaths per year, kind of reminding us the critical importance of not only kind of system level changes to improve control of these risk factors, but also the role of primary care to get people treatments that we know work to improve these risk factors. And I won't go too much into this slide, but diabetes and hypertension have a lot of similarities. They have similarities in terms of kind of common risk factors, obesity, kind of physical activity levels. They also share a lot of similarities in terms of their distal outcomes, pathogenesis, both macrovascular diseases in terms of stroke and heart attack, aortic disease, peripheral arterial disease, but also the fact that both can contribute to microvascular changes, retinopathy, neuropathy, and most kind of common, at least in the setting where I work, is chronic kidney disease, like the patient that I presented to you at the beginning. And I'll tell you more about him in one moment. And kind of the thesis statement, again, when I talk to the officials in the Ministry of Health, is reminding them how this synergistic management approach, not only focusing on the single risk factor, but the fact that kind of control of lipids, control of blood glucose, all go together. In a setting where we work, roughly 50% of all people with diabetes have hypertension, and maybe 25% of people with hypertension have diabetes. And so I try to remind the policymakers I work with that it doesn't make a lot of sense to just treat one of these risk factors and kind of ignore the other one. And in fact, when we talk to patients, they're often puzzled in the public clinic that are only offering hypertension care, for example, why this other problem they have is kind of not being addressed as urgently. And I alluded to this before, but HEARTS is an acronym for 6 implementation or quality improvement strategies to improve the system level care of hypertension, and also, as I'd like to argue, of diabetes. And to go through this just for one moment, the HEARTS, the 6 kind of elements of HEARTS include healthy lifestyle counseling, so that's the H, evidence-based protocols. And this is more than just trying as clinicians in primary care to, translate American Heart Association guidelines to the patient in a busy clinic visit, but rather trying to systematize these protocols so that they refer to drugs that we know are available to our patients, or try to facilitate the prescription of drugs that we know are available, to standardize the use of multi-drug regimens, and also to try to minimize the number of changes we might do. So kind of the paradigm that I've learned from Dr. Tepetti, who's on this call, and other hypertension experts, is really to get to the right drug at the right dose, not to tinker or to titrate, but really to make sure people can get to optimal control as quickly as possible, and then to monitor them to make sure that their care is safe. The other component, which is really an area of strong interest for me in my work in Latin America, is access to essential medicines and technologies. And so this is more, more than just making sure that we have payers who are willing to pay for the medications that we have, but really thinking about systems of care that can help improve access. In the US, for example, federally qualified health centers, as many of you I'm sure know, have access to the 340B programs, which can be such wonderful resources getting patients medicines at relatively reasonable costs. In the setting where I work in Guatemala, there's also some interesting similar arrangements where the Ministry of Health, for example, can purchase through bulk quality certified purchasers in ways that really brings down the cost, but also gets those medications to the primary health facilities, even if they're located in rural communities, like the picture I showed you at the beginning of the slide. In the case of diabetes, there's also been a lot of interested parties who've been interested in considering the role of novel diabetes medicines. And I'll talk about that in one moment, because those really are cardiovascular medicines. I'm referring to the SGLT2 inhibitors, the flozins, or the GLP-1 agonists, the tides. And I think the issue of those medicines really brings home how access to optimal diabetes care in the US and globally is really a challenge of cost. Getting those medications to people is a real big challenge. Even at the University of Michigan, among privately insured patients, it can be a real challenge. The fourth component of HEART is this risk-based CVD management. component. And to many of you who use, CVD risk scores to try to calculate whether a patient might be eligible for a consideration of using a statin in primary prevention, you're probably quite familiar with these tools. But outside of the US, they're surprisingly infrequently used. And in fact, in my work in Guatemala, I've never seen in a public clinic a CVD risk score implemented, even though it's part of the clinical protocols and guidelines nationally. The next part is team-based care. And this really emphasizes the role of task sharing or using non-physician health workers to help titrate, use some of these evidence-based treatment protocols that are developed that are standardized. In clinics where I worked in the US, for example, often it's pharmacists who are really taking up the mantle. Outside of the US, I work with a lot of nurses or nursing assistants who are able to titrate and to help to really extend clinical delivery of hypertension and diabetes care in places where there's just not enough physicians to be able to do that at a population level. And the final point is systems monitoring or using population data, not just clinic data or physician data to try to monitor population control. And so I wanted to just mention that last part a little bit more. Earlier last year, at the end of last year, I had the great privilege of participating in a World Health Organization working group to try to make new population level diabetes quality improvement targets, essentially. And this had already really been done, I think, in the hypertension or blood pressure sphere, but it was a very illuminating experience for me to be part of this World Health Organization working group. And in our paper, we have a policy paper that came out, and the final manuscript is currently under review. But basically, what was interesting to me is that there were basically four main population level indicators that we ultimately recommended. We recommended percent that are diagnosed, because even if we're just at a clinic, we might not know the patients that aren't coming to clinic, of course. And then among people who are diagnosed, we recommended monitoring blood pressure control, glucose control, and statin control. And I think that really shows you the fact that blood pressure and statin are equivalent in their importance at this World Health Organization, how important it is to really think about the blood pressure bits and the cholesterol bits as we treat our diabetes patients. I also wanted to take advantage of a recent paper that was just published last week and just give you my editorialization about how kind of this cutting edge evidence really fits into the kind of message I'm trying to convey today. Many of you may have seen this paper. It was the GRADE trial. It came out last week. And it was a study funded by NIH here in the US, multi-center, big trial. The University of Michigan was one of the sites. And it was a study that was started in 2012. And they were mostly interested in trying to figure out what would be the best second-line diabetes agent after metformin. And so patients ultimately were randomized after metformin to receive either insulin, glimepiride, so sulfonylurea, liraglutide, which is the GLP-1 agonist that I mentioned to you before, or sitagliptin. And what was really remarkable about this paper was just how much the cardiovascular benefit of some of these novel agents really made such a big difference. And I think it really speaks to the fact that we really need to work hard to get access to these medications. And so let me just walk you through this slide, because I think it really is of a lot of interest. The y-axis here is incidence of cardiovascular disease, and I think it's defined as any major adverse cardiovascular event, so heart attack, stroke, et cetera, whether fatal or non-fatal. And on the x-axis here is the year, and then you can see the different drugs here. So the blue here was the liraglutide, or the GLP-1 agonist, injectable GLP-1 agonist. And so I think that the take-home message from this trial was that although all of these four medications had about the same improvement in their ability to control blood glucose, that there seemed to be quite a good hint that there's some glucose-independent benefit to some of these novel drugs in reducing cardiovascular disease, which I didn't state this before, but it's the most common cause of death among people with diabetes. And you can see here that the hazard ratio, I think, was about 0.7 or 0.8. And so, these drugs are still so expensive, very difficult to get. And I think speaks to the importance of cardiovascular risk factor control among people with diabetes, not just focusing on our glycemic control or A1C among our patients. So let me just come back to this patient I told you about. As a reminder, he had diabetes for about 10 years, was in his early 40s, presented with some weight loss, decreased urination, and some bilateral pedal edema, worse in his ankles, maybe like 2+ pitting edema. And I work with this amazing group of community health workers and diabetes nurses in Guatemala, and we have a very kind of integrated, comprehensive program. And I was able to kind of connect him with our team of diabetes nurses, kind of our task sharing. And they do this amazing job of controlling our patients' risk factors and are very available. They make sure patients get on the right medication at the right dose as quickly as possible. And unfortunately, he had a creatinine of about 5. And so our diabetes nurses, they controlled his blood pressure over the next couple of months, and were able to control his glucose. He started gaining some weight, but ultimately he had to go on dialysis. And this is a picture of him, I think, in 2018. So about 5 years later, his wife, he did well on dialysis for about 5 years or so. But then just last year or 2 years before, he died of a heart attack. And, I sometimes think about his case. I got to know him very well and visited his home many times. And his case has been kind of a reminder to me about like how important it is to get quality primary care to these patients, and how, all these patients that we're missing are a lot of them are suffering really debilitating consequences, not just in terms of kind of morbidity and mortality, but also the consequences of his family not having their father or their husband around. And so that's kind of been a key motivation for me as I work toward really thinking about how we can improve diabetes care in the primary care level. So just if I might be able to just bring back to kind of my 3 main points. So first, there is a large implementation gap in hypertension diabetes care, worse in resource limited settings. In a lot of the challenges that we see in the US and in Guatemala are very similar. And I think HEARTS is a really state-of-the-art tool that is very adaptable to the settings, and I think has a lot of potential in the US, that's been shown by the Kaiser experience. And then finally, if I can bring this up one last time, is that high quality hypertension care or high quality cardiovascular care is such an important pillar of high quality diabetes care. And we must think of kind of multi-factor risk factor control if we really want to do best for our patients in primary care.